Hey everyone, this is going to be part 2 of the reproductive part, and this is going to go over more female and then male disorders, okay? So the first part had about the breast. So to get started, I have the PowerPoint right here. To get started, we have pelvic inflammatory disease, and this is really, an infection of the pelvic cavity. Usually could be in the cervix, can travel up the fallopian tubes, and generally this is somebody who's experiencing some kind of STD, generally gonorrhea or chlamydia. Obviously, people at higher risk could be sex workers, homeless, things like that. Of course, this can happen to anybody in the population, but those are the populations that have a higher prevalence of this. Can cause pelvic pain, can cause ectopic pregnancy. If not treated, can cause infertility. You can see how it can spread, depends on the infection, like gonorrhea can spread more to the, even to the ovaries. And eventually these things can start causing even sepsis if not treated. So how do you know somebody has this? They're going to have usually vaginal discharge, which is foul smelling. They're going to have lower abdominal pain. Sometimes even as they're walking, they don't really want to kind of stomp on the ground. I remember when I worked in the emergency room, sometimes when people had, sometimes some of the doctors say, oh, they have the PID shuffle because they didn't want to walk and stomp. They kind of gently walked. And that was sometimes a signal. Also, of course, with any infection, they're going to have, fever, fatigue, and they're going to have tenderness on palpation, especially of their uterus when on exam. Treatment is going to be antibiotics, of course, depending on the organism. You don't have to know, we're not going to test you on what to give. You should just know that giving the antibiotic, really important. Also treating, their sexual partners. Sometimes they're going to need pain medications and also education on how to, safe practices so that this doesn't happen again. The next part for female disorders is structural disorders. So you can see in this diagram, there's these little kind of gaps. And whenever there's a gap and a connection between two areas, that's called a fistula, right? So you can have a fistula between the vaginal and the rectal area. There can be fistulas between the bladder. And just think about it. This just creates a lot of problems because now you could have feces going to the bladder or urine going here, right? So this causes all kind of issues with the patient. So you can see here a vesical vaginal fistula is where urine escapes into the vaginal area. So they would have, urine leaking from the their vaginal area. A rectal vaginal fistula is where actually, you can see this feces going there. And now, of course, this would cause, problems with discharge, odors, and generally this is all treated with surgery. Other structural disorders. So generally, we could call this almost a pelvic floor weakness where people get cystocele, which is a bladder disorder, rectocele. And you can see in the picture here how it's almost like the part of the body is dropping, like the rectum is dropping lower, or even sometimes the intestines can drop or the bladder drops. And the patient, obviously, if it's of the bladder, they're going to have, pelvic pressure and urinary problems. If it's of the rectum and it's a rectocele, instead of urinary problems, they're going to have maybe rectal pressure or difficulty having bowel movements like constipation. Treatment could be surgery. We can also do these devices called pessaries, and also pelvic floor training, which would be, Kegels, where the person, just kind of pulls in their muscle for a bit. And there's many different types and shapes of these pessaries, and they get installed to the patient. You can see it here, right, where the healthcare provider is actually putting this kind of ring-shaped pessary in place, and this helps keep that part in there. And of course, the patient should still be educated to, keep doing pelvic floor training, and possibly if it doesn't work, they might need surgery because sometimes things like a uterine prolapse can happen where the uterus literally just comes right out through the vagina. And in a severe prolapse, they call this procedentia, where the uterus appears outside the vaginal area. And here you can see it even more. They're actually measuring it to see that the uterus came out through the vaginal area. So generally in these cases, surgery is there. Sometimes if it's really advanced and it starts to affect maybe the circulation, or if something gets strangulated, they might have to do a hysterectomy, which means they're removing the uterus. But oftentimes they try to begin with conservative measures, which would be, those pelvic floor training things, and maybe trying a pessary. Some patients, they have, this is another topic, a new topic now, ovarian cysts, and these are cysts that get filled with fluid. And many times this is related to something called PCOS, right? And PCOS, which is polycystic ovarian syndrome, is when it's very common in women who are overweight. You can see there's obesity. Oftentimes they also have diabetes. They might have high cholesterol. And what it kind of happens is the ovary starts to have malfunctions. And now, instead of maybe the normal estrogen levels and the normal hormonal levels, maybe more of the masculine hormones are taking over. They might have hair loss, like male pattern baldness. They might start getting hirsutism, like, hair on the face, things like this. Infertility issues because the hormones just are not functioning as they should. Medical management, sometimes they might actually do, a mastectomy, depending on what's going on. Many times we just use hormonal treatments to treat this, and obviously weight loss therapy as well. You can see uterine fibroids are here. And in this case, uterine fibroids are just also what they sometimes could say a myoma, where, because the uterus is really a muscular organ. So these are, areas where there's growth inside that muscle. And they usually are pretty slow growing. They can happen between 25 and 50. And if you think about it, if there's something in the muscle, it's going to affect menstruation. It's going to affect pain, right? So it might be more painful or more blood involved with the person's menses. Also, they might feel more pressure, even because if it's pushing maybe on their back, or it could be pushing on their rectum, causing constipation. It could even interfere with fertility because the egg can't attach if there's fibroids, and then the muscle can't hold of the uterus to hold the baby there. So medical management, if the person wants to bear children, they were going to try and do a myomectomy, where they just remove the part of the muscle that has a fibroid. But sometimes if a person maybe isn't choosing to have a child, or they've already had their children, they might do a full hysterectomy for that patient. And you can see here, right? So hysteroscopic resection is just where hysterectomy means you're removing the uterus. And sometimes people get confused. There's something called a TAH BSO. So TAH means total abdominal hysterectomy. That means the uterus is being removed. The BSO part means bilateral sapho-oophorectomy, which means that's removal of the ovaries. And you can do one or the other. So, or many times they do both. So they can just do a hysterectomy where they just remove the uterus. And then other times they might just do something where they remove the ovaries. Obviously, anytime they remove the ovaries, the person's going to go into automatic menopause, right? So they might need hormonal treatment if they don't want to go through those symptoms right away. But that's something to keep in mind. Endometriosis, this is where endometrial tissue starts growing outside of the uterus. You can see here that tissue will bleed. So oftentimes it causes, bleeding outside the normal menstruation period. That's a very, very common symptom. Also, this is more popular, more like there's a higher incidence in women who have not had children. Oftentimes it causes menstrual pain. It can cause pain with bowel movements. Even pelvic pain can cause infertility. And generally, patients that have endometriosis, they're really complaining of very severe and kind of like ongoing menstrual pain. In this case, they might be taking analgesics to help that pain. And many times they'll give hormonal therapy to try to relieve it until they can really do surgery, because surgery is sometimes needed to get rid of, those that excess tissue that's growing outside. You can see they could do this with laparoscopy. They could do it with laser. There's many, many things. When somebody, has these things, the real goal is to relieve their pain and really get their menstrual cycle back to, something that they were used to, back to what they had before. So you can see malignant disorders of the female tract. Well, this is when, people start getting cancer. And one big thing I always remind people whenever I think about cancer and reproduction in females is the risk of bleeding, and not the risk of bleeding, the risk of clotting is very high, and DVTs and pulmonary embolisms. So keep that in mind, because all the hormonal changes plus the surgery they might be having, it's really a high risk. I've seen patients actually die in front of my eyes of pulmonary embolisms when they had reproductive cancers. Cervical cancer is very common. Obviously, we know it's linked to HPV. And if a person doesn't get their regular checkups, they will be at high risk of, not detecting that they have cervical cancer. I actually remember there was a patient, her best friend growing up was her gynecologist. And the gynecologist would just kind of, she would go for her visit and he'd go, "Do you really want me to examine you?" She's, No, I'm good. Everything's fine down there. And guess what happened? 5 years into it, she actually had advanced cervical cancer that was not detected. And she had to not only have her cervix removed, but it had spread all locally into her vaginal area, into her rectal area. She had to have an extentoration, where she actually had to have her vaginal area removed, and then they had to put in a prosthetic piece. And even her rectal area, she had to have a colostomy. It was a very complicated, an unnecessary thing that she had to go through for that. So the big thing is you want to tell your patients, get your, cervical, examinations done. Because if you catch it early, look at what the treatment's very easy. They can just do cryotherapy and just freeze off the area that's affected. But if they wait, it's a very, very involved surgery where, look, you might have to be getting a total hysterectomy. But down here, you can see pelvic extentoration. It's removal of the pelvic organs, bladder, rectum, lymph nodes, and then they reconstruct, even because they're taking out the bladder, they have to reconstruct the bladder with what they call a diversional conduit, give them a colostomy, and actually replace the vagina. I remember the case was it wasn't pleasant for the person. Big lawsuit for the physician and everything involved. So with anybody who's had this kind of surgery, always make sure, you're assessing the patient for bleeding and assessing the patient and monitoring for PE and doing all DVT prophylaxis in these patients. Of course, chemotherapy, radiation can be used for any types of these disorders. You can see, actually, we don't have to cover this part with uterine cancer, not really. Ovarian cancer, this is one of the most deadly types of cancers. So it's really very hard to detect. The big thing a lot of people do is they might, if you have a family member like mother or sister who had it, some people will prophylactically remove their ovary just so they don't get it. But you can see the symptoms. It happens very quickly. It's very deadly, very fast. Increased abdominal girth, bloating, all these different symptoms are there. But again, very, very hard to treat early. So I'm going to skip down a little bit. We've kind of talked about lymphedema. You can look at these things. These are different chemotherapies. Hysterectomy, again, we spoke a little bit about. You really want to, monitor the patient for all those pieces. What I really want to get to is for the male, right, to end with that. So for testicular cancer, right, in males, that's really the one that comes up. And you can see the common ages is kind of young, 15 to 40. It is treatable and curable if found. And if somebody has a history of undescended testicles when they were very young, or a positive history in their family of testicular cancer, that's a risk. Being Caucasian is a risk. And oftentimes what testicular cancer is it's a painless lump or mass in the testes. And just like when we talked about female breast exams, same thing, you can see the testicle would actually have that feeling of like a gritty kind of piece-shaped piece in there. And then the treatment generally is radiation and surgery, and they can actually replace the testicle. And that really covers reproductive part 2. Okay, everybody? And that's it for now. Thank you.